First of all, a very good morning, everyone. And I would like to thank Dr. Bansi Sabu sir and the entire organizing team for inviting me, and thanks to Chairperson for the very kind introduction. So this is a debate, and I will be debating on the topic that is translating CVOT evidence in diabetes into practice. So I will be talking on behalf of the challenges. Now, cardiovascular outcome trials have indeed revolutionized the diabetes management. We know since the rosiglitazone debacle in 2008, the CVOT came into existence, and from there it has given us the 3-point MACE neutrality of the DP4 inhibitors, and also the heart failure signals that came out of it. And from there we have leaped onto the era of the SGLT2 inhibitors and the GLP-1 receptor agonist with cardioprotective benefits. These are all true. But despite the clear benefits, implementation faces significant real-world barriers, and we need to understand these challenges at the very core to make the next step of progress towards overcoming them. So if you look at the current status of the CVOT implementation, so we have the SGLT2 inhibitor and the GLP-1 receptor agonist adoption trends. So in the United States, there is data on type 2 diabetes and established cardiovascular disease patients. Only 27% of the eligible patients were on the recommended therapy. The number has increased from a dismal 9% in 2018 to about 27% in 2022, but yet we have not achieved the actual rate what we want. And the global implementation rates are even lower, so it's about less than 10% in the Europe. And the comprehensive guideline adherence is actually below 5% in most global settings. So no matter what's there in the CVOT evidence, we have not been able to translate that into real clinical practice. So what are the challenges? So challenge number one is the generalizability of the CVOT result. So the typical CVOT participant is either having an established cardiovascular disease or at a very high risk or with multiple comorbidities and age usually 60 years or more. But in the real world, in about 70 to 80% of the actual patients, they don't actually fit this CVOT participant profile. So they are much younger and they are at a much lower risk of the spectrum. So clinicians are obviously sometimes uncertain about applicability of this CVOT evidence in the real world. The challenge number two is clinical inertia in the practice. So we all know that therapeutic inertia can actually slow the adoption of whatever practice we are planning to for any new medication, whatever treatment paradigms arrive, we will be slowing if there is a therapeutic inertia. And as we are transitioning from the old glucocentric mindset to the organ-centric mindset, this clinical inertia is a big barrier. So what are the causes of the clinical inertia? So there is limited awareness or familiarity with the latest evidence, concerns about managing the effects or the drug interactions. There are very short clinic visit times, and very important is the psychological factors that why change what's working. So a clinician might think the HbA1c is under control, the patient is doing otherwise well. Why bring in one additional drug into the patient's treatment profile and disrupt the entire thing? So they might have that kind of clinical inertia. The third and very relevant for us is the cost and the access barriers. So the SGLT2 inhibitors post patent loss, the drug prices have come down, but for GLP-1s it's still expensive. So in the United States, about $700 to $1,000 per month, and in India, more than 10,000 rupees per month here in India. And some of the studies show us that a cost reduction of about 70 to 90% is actually required for these agents for them to become cost effective if you're trying to use them as a first line agent. Challenge number four is healthcare system complexity. So you have the evidence and the guidelines in your hand, but if you try to implement them, so you face real-time barriers like the formulary committees, the lack of decision support in the EHR system, the insurance approval, and the coordination difficulty. And all this can be a challenge of implementing this important CVOT evidence into your patient care. And if this was not enough, then interpreting the complex CVOT evidence is another layer of challenge. So comparing drugs across different trials is not very straightforward. Trials can differ in design, inclusion criteria, and endpoints, and the results can be very nuanced. So some drugs might reduce the heart failure but not stroke, and maybe vice versa. Challenge number 5 is patient factors. So patient is at the very core of our treatment policies, right? So they might have acceptability issues with injectable therapies like the most GLP-1 receptor agonist. Then there might be side effects that may lead to discontinuation, like the GI side effects and the genital infections with the SGLT2 inhibitor. And remember that benefits are long-term. So whatever benefits we are talking about, the cardio-renal protection, are usually very long-term and are not immediately tangible to the patient. So patient sometimes wants more tangible benefits which they can, feel right away. So I have listed some of the counter arguments that usually come up when we discuss about the challenges. So see, the trends have been improving, so there has been a tripling from the lower base. But if the base is already very low, even if you triple, you won't be able to achieve much. So you see 27% receiving, as I told you, in established type 2 diabetes and established CVD patients, the number is 27%. So nearly 3 out of the 4 eligible patients are still not receiving the therapy, and the comprehensive guideline practice is below 5%. The second counter argument usually is that most of the major guidelines have incorporated the CVOT evidence into their, written as a written document, and then medical education is trying to improve this. But remember that guidelines has been in place for years, yet practice gap can still persist. Many patients never see specialists familiar with this medication, and cardiologists prescribing of GLP-1 receptor agonist still remains low. So one study in the US showed that it's less than 2%. Now, then there are the success stories and the outcomes. So see, we have, wherever we have implemented the studies, it has shown quite good outcomes. Better A1C result plus weight loss, and the real world evidence confirms whatever we have seen in the CVOT benefits. But the actual truth is that benefits occur to a relatively privileged patient subset, and even racial and ethnic disparities in who receive these medications has been noted. Some of the studies from the US shows that Black and Hispanic patients were less likely to receive the therapies than the white patients, and the most real world studies that as a counter argument is quoted still classify these therapies as underused. The fourth counter argument is that cost will eventually improve. So over the time, the drugs will lose their patents and the drugs prices will come on, and we will be able to use them more often. But the rebuttal is that patients need the protection now. So patients need cardiovascular protection today and not maybe in 5 to 10 years. And this interim period may potentially actually prevent thousands of events. And even if the generic prices come down, that in the US is expected that it will drop by 1/3, it will still be $300 per month in the United States for GLP, and in India it will be about 4,000 rupees per month, which will still be costly if it is out of pocket. So if we put the challenges and the opportunities on a scale and try to balance them and see, still challenges weigh heavier than the opportunities it present to us. But acknowledging this fact is not the same as denying progress. We need to be very realistic in our assessment that where we stand today, so that we can make accelerated improvement to implement the CVOT evidence in the future. Thank you very much for your patient listening.